We're going to finish up talking about blood vessels, and so the majority of what we're talking about here is going to be on blood flow and blood pressure. So right now I want to discuss your cardiovascular responses to decreased blood flow, blood volume, and blood pressure. So your body, this is like on a normal day-to-day basis when you have fluctuations in volume and blood pressure. The first response of your body is going to be what we call autoregulation. Autoregulation. It's under a normal condition, but if you have slight fluctuation in blood volume or blood pressure, autoregulation should be able to correct it. It's an immediate response. It happens immediately. And it occurs because the precapillary sphincters respond to what we call vasodilators. So let's talk again about what those precapillary sphincters are. So over here I have some blood vessel. This is like an arteriole. And this is a capillary, right? So we've got these capillaries. There's one, and then there's a capillary too. So we have these capillaries, and when the blood goes from the arteriole into the capillary, it has to go through this sphincter type muscle right here that's at the start of the capillary, and that's called the precapillary sphincter. So when the precapillary sphincter is contracting, it's actually going to decrease the diameter of the capillary, and less blood can go into that capillary, which means less blood is going to flow into that tissue. But when there's these things in the blood that are called vasodilators, then those precapillary sphincters are going to relax, and the capillary is going to increase in diameter, and more blood flow would then go to those tissues. So now we want to look at, what are vasodilators? What are those things that we call vasodilators? What are going to make those precapillary sphincters relax so that more blood can go into that vessel, into that capillary, and then go to the tissues? So these precapillary sphincters are responding to the interstitial fluid. They're not responding to the blood in the arteriole. They're responding to whatever is going on in that interstitial fluid, right? Because that's going to determine, does that interstitial fluid and that tissue, does it need more blood or does it not? So it's really responding to the interstitial fluid. So is there decreased oxygen in that interstitial fluid? Well, if there's decreased oxygen in the interstitial fluid, that means the tissues have been busy using up oxygen and they now need more oxygen. So those blood vessels will dilate. Is there a decrease in pH? Whenever the tissues are busy metabolizing, more hydrogen ions are being released and the pH level is going to decrease. Does the interstitial fluid have an increase in CO2? Well, we know that if tissues are really active, they're going to produce CO2 as a waste product. So if they're increasing all of these things here, they're telling you that the tissues are active and the tissues need more blood. So those are vasodilators. They are going to make those precapillary sphincters relax, and it's going to increase the diameter of the capillaries. Other things, if there's lactate in the tissues, that means the tissues are active. If there's inflammatory chemicals like prostaglandins and histamine, if some of your immune cells have released prostaglandins or have released histamine, that means that there's an inflammatory condition going on in that tissue, and that tissue needs more blood. It needs more oxygen, it needs more cells, immune cells, so those capillaries will increase in diameter. We knew that nitric oxide, if nitric oxide is released, then that's going to relax the smooth muscles of blood vessels. And then we know also if temperatures increase, that means the tissue's active again. So all of these things can be considered vasodilators. They're going to relax that precapillary sphincter more blood is going to go into the precapillary sphincter, and that tissue is going to get more blood. Okay? So these things are going to, they're going to happen just naturally on a day-to-day basis, just rerouting blood to whatever tissue is the most active at the time, right? But if that doesn't work, if this autoregulation doesn't work, then the body is going to go to two other responses. It will have two other responses. One response is the nervous system, and the other response is the endocrine system. Okay, so if autoregulation doesn't restore homeostasis, doesn't keep the blood volume and the blood pressure where it's supposed to be, the nervous system and the endocrine system are going to kick in. And they kick in at the same time, but the nervous system is going to be a short-term response. We always knew that. The nervous system does short-term responses, whereas the endocrine system is really going to be a more long-term response. So in other words, really, the nervous system is going to help to increase blood pressure, whereas the endocrine system is going to help to increase blood volume and blood pressure, right? So we're going to go through each one of those individually. All right, so we're going to start by looking at the nervous system. Okay, again, the nervous system is a short-term response. Basically, what it's going to do is increase blood pressure. The nervous system response includes these baroreceptors and chemoreceptors that we've heard of. They are the receptors that are going to detect that the blood pressure and blood volume have dropped. So if we look at where those baroreceptors and chemoreceptors are found, this is a crude drawing of the aorta. Here's the brachiocephalic trunk. Here is the left common carotid, and then this is the left subclavian. All right, so we're just kind of looking at those. There are baroreceptors and chemoreceptors in the arch of the aorta. So these little black dots I drew here, that is where baroreceptors and chemoreceptors can be found. And then also where that common carotid artery splits into the internal carotid and the external carotid, there's also baroreceptors and chemoreceptors right there. So we know baroreceptors are detecting pressure, and chemoreceptors are detecting chemicals like oxygen, carbon dioxide, and pH. So we learned that in chapter 15 when we were talking about receptors. The baroreceptors and chemoreceptors, we're going to look at these on a different page. We're going to go further into depth with this, but when they are stimulated, when they become stimulated, they're going to activate the cardioacceleratory center in the medulla. And then that cardioacceleratory center is going to activate the sympathetic nervous system, and then the sympathetic nervous system stimulates beta receptors in the heart to increase the heart rate, alpha receptors on blood vessels, which causes vasoconstriction, and now we've increased the blood pressure. The vasoconstriction is going to increase blood pressure directly, and increasing the heart rate is going to increase blood pressure indirectly by increasing cardiac output. The harder the heart beats, the faster the blood is getting pushed out, the more blood pressure there is. So this is a very short synopsis of what's happening here, but I'm going to go into it in greater detail on the next page. So we end up with a short-term increase in blood pressure because of these baroreceptors and chemoreceptors detecting that the blood pressure has fallen. There's another center that we're going to look at too that's called the vasomotor center. So not only do we have in the medulla, we don't just have the cardioacceleratory and the cardioinhibitory centers, we also have a vasomotor center, and we're going to look at that in more detail. So I'm just giving you an overall view of this, and we'll look at it a little deeper, right? Then we look at the endocrine response, and again, this is just an overview of it, and we're going to get into this in more detail. So the endocrine response is the long-term response. It's going to increase both blood pressure and it's going to increase blood volume, right? Because blood volume takes a while to get that blood volume back up. Blood pressure you can do pretty quickly. Blood volume is going to take a little bit of time to get that volume back up. So it's a long-term solution to decreasing blood pressure and decreasing blood volume. The receptors are going to be found in the kidney, and as blood comes into the kidney through the renal artery, those receptors are going to respond to that decrease in blood pressure and also to oxygen levels, right? So it can detect, those receptors in there are detecting these changes. So you might not remember, but it's in the juxtaglomerular complex, and we're going to talk about that when we get to the renal system, right? But those receptors are detecting that decrease in blood pressure and the decrease in oxygen levels that go along with that, since there's less blood coming in. And when that happens, the kidneys then are going to respond by releasing erythropoietin, which will target the red bone marrow and cause you to make more red blood cells, which will increase blood volume and blood pressure. And the kidney will also release renin. And again, we're going to look at this in more detail, but renin causes eventually the release of ADH and aldosterone, and that increases water reabsorption and sodium reabsorption, right? So that's causing you to retain water. So if you're retaining water, what's happening to your blood pressure? It's going back up, right? So again, this is the response to when you have decreased blood pressure, decreased blood volume. So EPO and renin get released, and then also the kidney, the renin is also going to make you more thirsty. So you're going to be drinking more, which will also increase your blood volume, which increases your blood pressure. So that's the response would be that you are retaining water at the kidneys, and so that increases your blood volume, which increases your blood pressure. Again, this is an overview. Let's look at that centers that we've been talking about in the medulla oblongata. So this picture here is showing you the brain stem. There's a dotted line right there. The medulla oblongata is here, and then the spinal cord is right below it, so you can just kind of see where we're at. So we know that in the medulla oblongata, we've already learned that there is a cardiovascular center. And in that cardiovascular center, we know we have the cardioacceleratory and the cardioinhibitory centers. Both of those centers can be stimulated or inhibited, okay? And when they can both affect cardiac output. So when the cardioacceleratory center is stimulated, it's going to increase cardiac output. And that's going to indirectly affect the blood pressure then. If the heart beats stronger, then there's going to be more pressure coming out, so that's going to increase blood pressure, right? But if that cardioacceleratory center were inhibited, then it's going to not increase cardiac output. So the cardioacceleratory center can be stimulated or inhibited. Then we have the cardioinhibitory center. The cardioinhibitory center is going to cause the heart to not contract as fast, not contract as hard. So it's going to decrease cardiac output. So the cardioinhibitory center can be stimulated or inhibited. Almost all the time, if the cardioacceleratory center is inhibited, the cardioinhibitory center would be stimulated. So you're not going to stimulate them both at the same time. That's what I'm trying to say. And you're not going to inhibit both of them at the same time. One will be stimulated while the other one's inhibited. So look at the one that's being stimulated. That's the one that's going to tell you what's going on. Cardioacceleratory center increases heart rate, increases contractility. Cardioinhibitory center decreases heart rate, decreases contractility. Okay? All right, well, there's another center here that's called the vasomotor tone. Or not tone, the vasomotor center. the vasomotor center. So cardioacceleratory, cardioinhibitory, and then vasomotor center. The vasomotor center has two groups of neurons. It has one very large group of neurons, and then it has a smaller group of neurons. This is supposed to be a neuron with the axon terminal right there. So the large group of neurons is what we're used to we're used to talking about. That vasomotor center is what gets, it stimulates the sympathetic nervous system. And it releases norepinephrine so that it'll bind at the alpha-1 receptors. So whenever I've been talking about, the sympathetic nervous system and norepinephrine binding to alpha-1 receptors, what does that do when norepinephrine binds to the alpha-1 receptors? Right, it vasoconstricts all the peripheral, most of the blood vessels, right? The majority, widespread blood vessels. So most of the time when the vasomotor center is stimulated, it's going to cause vasoconstriction of your blood vessels, and you're going to increase blood pressure. When it's being inhibited, then it's not going to cause vasoconstriction, right? But there's a smaller group of a smaller group of neurons from the vasomotor center that are going to blood vessels in other places. So to the brain, to the skeletal muscles. And we've talked about this before too. This is that exception to the sympathetic nervous system. This is when the neurons do not release norepinephrine. It's when the neurons are releasing acetylcholine, and they're binding to receptors on the blood vessels, muscarinic receptors, and they're causing nitric oxide then to be released, which causes vasodilation. So if you remember, in the sympathetic nervous system, most of your blood vessels are constricting from the larger group, but the blood vessels going to the brain and the skeletal muscles, they're going to dilate. Because when you're in fight or flight, you need more blood going to your brain and more blood going to your skeletal muscles. Your brain will make you, more blood to the brain makes you think faster. More blood to the skeletal muscles gets you ready to run away. So that's the smaller group. But that's what we get from the vasomotor center. All right, so let's look at this thing that's called vasomotor tone. Vasomotor tone. So that large group of neurons from the vasomotor center is always active at a background level. So the sympathetic nervous system is constantly telling your blood vessels to vasoconstrict, always at a background level. The arterioles and the arteries are always slightly constricted, so we have that little bit of vasomotor tone to it. And because of that, it really helps to control the blood pressure, and you can only just make moderate adjustments then to the diameter of the blood vessel, and you'll get huge changes in the amount of blood flow. So if we look at these pictures here, this is just a resting arteriole with vasomotor tone. The sympathetic nervous system is just, it's working at a resting level. So it's instead of saying not activated, we could just say it's at a resting level. The sympathetic nervous system. So it's causing a little bit of vasoconstriction here, right? But if the vasomotor center becomes stimulated, that's the sympathetic nervous system, you're going to get maximal exertion, and those arterioles can actually vasoconstrict to a half of their original size. And that's going to cause a huge increase in blood pressure. But if that vasomotor center is inhibited, so that means the sympathetic nervous system is inhibited, then the diameter of the blood vessel will become fully dilated, and it can increase the diameter about 1.5 times its resting size, its resting diameter. So the vasomotor center is really a sympathetic nervous system center. It's always going in the background, but if it becomes stimulated, it's going to cause even more vasoconstriction, and if it's inhibited, it's going to cause vasodilation. All right, so let's go back now and let's look at the baroreceptors and the chemoreceptors in a little more detail. Let's see how they're working. So first, let's look at your normal blood pressure. Say your normal blood pressure is around 120/70, right? So we've got normal blood pressure, and all of a sudden your blood pressure increases. Well, those baroreceptors, which are in the arch of the aorta, and they're right where that common carotid splits into the internal and external carotid, they become activated. You know, they sense, when they're activated, that means they sense something's going on. Well, what did they sense? They sensed that the blood pressure was going up, so those baroreceptors become stimulated. And those baroreceptors then are going to send a message through nerves to the medulla oblongata, to the cardiovascular center. Because we have increased blood pressure, we want to bring that blood pressure down. So the cardioinhibitory center is stimulated because that will decrease heart rate and that will decrease cardiac output. At the same time, the acceleratory center is inhibited. So we're more concerned, though, that the cardioinhibitory center is stimulated. It's stimulated. At the same time, so both of these things, by inhibiting the cardioacceleratory center and stimulating the cardioinhibitory center, your cardiac output goes down because your heart rate goes down and your stroke volume goes down. So we decrease cardiac output. The vasomotor center gets inhibited because remember, vasomotor center is the sympathetic nervous system. So we're going to inhibit that vasomotor center. And that's going to cause those blood vessels then to dilate up to 1.5 times their normal size. Well, 1.5 times their resting size. So we're vasodilating and we're decreasing the cardiac output. That's going to bring the blood pressure down, and now we're back to normal. Now we are back to the blood pressure being 120/70. So let's look at the opposite scenario then. Let's say that the blood pressure has increased. The blood pressure has decreased. We just went over increase. Let's look at the blood pressure decreasing. So again, the blood pressure is decreasing at that aortic arch and at that place where the common carotid splits. So again, the baroreceptors become activated. Activated just means those baroreceptors sense that something's wrong. Blood pressure is decreasing. So now the baroreceptors are going to become inhibited. When the baroreceptors are inhibited, the cardioacceleratory center becomes stimulated. That's going to increase heart rate, increase stroke volume. That means that cardiac output increases. So we get an increase in cardiac output. And at the same time, the cardioinhibitory center is inhibited. And then the vasomotor center becomes stimulated because, again, that's your sympathetic nervous system. So that is going to increase the release of norepinephrine at those alpha-1 receptors, and we're going to get vasoconstriction. So vasoconstriction and increased cardiac output. Vasoconstriction is going to increase blood pressure directly. Cardiac output is also going to increase blood pressure just in a more indirect way. So that's how baroreceptors work. So now let's look at chemoreceptors. You need to learn these blood chemical levels. We're going to be going over these again when we get to acid-base. And so you need to memorize the numbers. Might as well do it now. Your pH of your blood should be 7.35 to 7.45. If it's below 7.35, it's acidic. If it's above 7.45, it's alkaline. PaO2 means the partial pressure of oxygen in your arteries. Okay? So it's the partial pressure of arterial oxygen. Okay, partial pressure of oxygen in your arteries. That number is normally 75 to 100 millimeters of mercury. The partial pressure of carbon dioxide in your blood, in your arteries, is 35 to 45 millimeters of mercury. Carbon dioxide is kind of like an acid in your body. So if the partial pressure of carbon dioxide is greater than 45, and we'll go over this later. If it's greater than 45, it's actually making your blood more acidic. If it's less than 35, it's making it more alkaline. We're going to go over that at a later date. Yes?
That respiratory acidosis.
So we're not going to go into that, but that is what I'm talking about. When we start talking about alkalosis, acidosis, we're going to be using the pH and the PaCO2 numbers, right? But I don't want to get into that now. All right, so chemoreceptors. Again, the chemoreceptors are in the same place as the baroreceptors. They're in the arch of the aorta, and they're right where that common carotid artery splits. And so those chemoreceptors are detecting chemicals. They're looking at the chemicals. They're looking at carbon dioxide levels, they're looking at oxygen levels, and they're looking at how many hydrogen ions are in the blood. So if you have more hydrogen ions in the blood, that means your pH is decreasing. More hydrogens mean you have a lower pH. Less hydrogen mean you have a more alkaline blood. So it's looking at basically hydrogen ions, carbon dioxide, and oxygen levels in the blood. If carbon dioxide levels increase, not good. Carbon dioxide, your body thinks is an acid. It doesn't want to be too acidic. It doesn't want that pH to be too low. If you have decreased pH or decreased oxygen, those things are going to activate the chemoreceptors. And when they activate their chemoreceptors, they're going to stimulate them. So they stimulate the chemoreceptors. The chemoreceptors go to the medulla oblongata. They're going to end at the Cardiovascular Center in the medulla oblongata, and they're going to end at the Respiratory Center in the medulla oblongata. So in the Respiratory Center, it's going to increase your respiratory rate. You have too much carbon dioxide, and so you need to blow that out. And you don't have enough oxygen, so you need to breathe more in. So the Respiratory Center is, by increasing the respiratory rate, you're going to help that. You're going to get rid of carbon dioxide, and you're going to bring in oxygen. Then we have the cardiovascular centers. The Cardiovascular Center is going to be stimulated. We want to get more blood to the lungs so that we can breathe out that carbon dioxide and we can breathe in that oxygen, and the oxygen will go into the blood and the carbon dioxide will leave the blood. We need more blood going to the lungs. That's the only place we're going to be able to pick up more oxygen and get rid of the carbon dioxide. And then, of course, because the Cardiovascular Center is stimulated, the Cardioinhibitory Center will be inhibited. They just go hand in hand with each other. The Vasomotor Center will be stimulated, and that's going to create vasoconstriction because that is your sympathetic nervous system. That releases norepinephrine, that binds to your alpha-1 receptors, it causes vasoconstriction. And that's going to cause an increase in blood pressure, and that's what we wanted to do in the beginning, right? So we increase blood pressure directly through vasoconstriction, and we increase blood pressure indirectly by increasing the cardiac output. So that's how the chemoreceptors work to increase your blood pressure when your blood pressure is decreasing, which is the issue that we originally started out with, decreased blood pressure. Now let's talk about hormonal regulation of blood pressure and blood volume. So remember, hormonal regulation is all about the kidneys. And so we'll start by looking at what happens if we have an increased blood pressure or an increased blood volume. So here we have a normal, this is homeostasis right here. Blood pressure 120/70, blood volume about 5 liters, right? Just normal homeostasis. And now we get an increase in blood pressure and an increase in blood volume. Autoregulation didn't take care of that, so now We have to enlist the kidney, and in this case, because we are doing an increased blood pressure and blood volume, I actually have to talk about the heart. So let's talk about if your blood pressure is increased and your blood volume is increased, right? So the blood that is going into the right atrium, if there's increased blood volume and an increased blood pressure, it's going to push against the walls of the right atrium. Do you remember what reflex we got when we had pressure increasing in the right atrium? It's a reflex called the Bainbridge reflex, right? The Bainbridge reflex. Well, another thing's going to happen here too. When we get increased blood pressure and blood volume into the right atrium is going to release these two hormones called ANP and BNP. ANP stands for atrial natriuretic peptide. So ANP is the one that we are mostly looking at. BNP means brain natriuretic peptide, and it actually is, it's released from the ventricles. But we don't talk as much about the BNP. We talk about the ANP, atrial natriuretic peptide. So the blood's coming into the right atrium, and the right atrium is stretching and saying, whoa, we have too much blood pressure. There's too much blood. We need to do something, and we need to get rid of this. So ANP gets released by the heart. This is the heart right here. And ANP travels to the kidneys, and it binds to the kidneys, and it travels to the blood vessels, and it binds to the blood vessels. At the kidneys, ANP will cause the kidneys to lose water. They'll make you excrete water. Make the kidneys excrete water. Get rid of that extra water. So instead of reabsorbing the water at the kidneys, you're going to excrete it in the urine. ANP also causes you to, and I know on your sheet it says increase, change that to decrease. It decreases your thirst. Your blood pressure's already high. The blood pressure's high, the blood volume's high. The last thing you need is to drink more water and take in more fluid. So it decreases your thirst. And then it also inhibits renin. Inhibiting renin is going to inhibit ADH and aldosterone. That's going to decrease the amount of fluid, amount of water that's reabsorbed in the kidney, so you're going to excrete more in the urine. All of these things here, they lead to decreased blood volume. If you're urinating out more water, you're going to decrease your blood volume, right? Isn't that the whole purpose of a diuretic? Is to make a person urinate more, to get rid of the urine, to decrease their blood pressure. And then the decreasing of the thirst, that's so that you're not adding more volume to your extracellular fluids. So you're not increasing your blood pressure. You're going to decrease it if you're not drinking as much. At the blood vessels, ANP will cause vasodilation. So again, that too is going to directly affect blood pressure. It'll decrease the blood pressure. And now you go back to normal. Back to normal. All right, so that's what happens if you have increased blood pressure and increased blood volume. Now let's look at the endocrine response if you have the exact opposite situation and we have decreased blood pressure and decreased blood volume. So now your blood volume is decreasing, blood pressure is dropping. We've already talked about this before, just going over it again. Your baroreceptors are going to become stimulated. This is the short-term response. It activates the sympathetic nervous system. That releases norepinephrine and epinephrine. That's going to create an increased cardiac output by increasing your heart rate and your stroke volume. It's also going to bind to the alpha receptors and cause vasoconstriction, and all of those things cause a short-term increase in blood pressure. Your kidneys at the same time are going to be involved, and they're going to help with a long-term response to this situation, to the decreased blood pressure and blood volume. The kidneys release erythropoietin. Erythropoietin targets your bone marrow and increases your red blood cell production. That causes an increase in red blood cells. If you have more red blood cells, you're going to increase your blood volume and you're going to increase your blood pressure, just because you're adding more to the whole blood. Kidneys also release renin. Renin is going to cause the increase of ADH, which gets secreted from the posterior pituitary, and increase the secretion of aldosterone, which is from the adrenal cortex. And together, ADH and aldosterone will cause the kidney to increase the water retention. You're going to have more water retention. That's what ADH and aldosterone do. You retain more water. If you retain more water, your blood volume goes up, your blood pressure goes up. Renin also has you have an increased thirst. You're increasing your water intake. That's also going to increase blood volume and blood pressure. It's long-term because it doesn't happen that quickly. You know, the sympathetic nervous system response from the baroreceptors, that's fast. The nervous system's very fast. The response from the hormones, EPO and renin, that takes longer. So that's a long-term response to a decrease in blood pressure and blood volume. I'm going to talk about a couple of organs that are controlled by different mechanisms. So we just want to know about these. For instance, the brain. Okay? The brain has a high demand for oxygen. It needs a substantial supply of blood at all times. It doesn't matter what's going on in the body, the brain needs its oxygen. It needs its supply of oxygen. It will always receive 12% of the cardiac output. Even if the body is going through a cardiovascular crisis, the brain needs the blood, all right? So it's always going to get 12%. Now, inside the brain, though, in different situations, the brain's going to adjust from moment to moment, so the blood's going to go to specific areas. So when you read, it's going to go to the area of the brain where it's active for reading. When you're writing, it's going to go to that area where that you need the brain active for writing. Same thing for speaking and walking. So the blood is going to adjust to whatever your activity in your brain is. The brain is going to receive blood through the 2 internal carotids and the 2 vertebral arteries. And if there is a slow developing interruption of blood supply in the brain, then anastomoses will occur. So an anastomosis is going to look more like this. Let's just say you have a blood vessel and you get a slow developing clot. Something is closing up that blood vessel. Then an anastomosis will occur where that blood vessel will kind of develop another blood vessel going over to another arteriole so that tissue can still get the blood supply. So it develops a connecting branch. That's what an anastomosis is, right? So that works if there's a slow developing interruption. But if there's a fast developing interruption, then that is not going to be the case. And a lot of what can happen in that case, if it's in a small blood vessel and the blood vessel is weakened, then that blood clot can actually cause a weakening of the blood vessel wall and will even rupture a weakened one. So it'll either completely block it or it'll weaken it. So if that happens suddenly, right? If it happens suddenly, that is a stroke or a cerebrovascular accident where the blood supply going to a certain area in the brain is just shut off. But if it happens more slowly and it progresses more slowly, then the blood vessels have a chance to build that branching, connecting anastomosis. The next organ that I want to talk about is the heart. So the heart, there's an elastic rebound that's going to force the blood back into the coronary arteries, right? So if we look at the heart, here we have the heart, here we have the aorta, here we have the coronary vessels coming off of the aorta, right? The coronary arteries will actually dilate if the heart has an increased workload. So if the heart is really working hard, increased contractility, increased heart rate, then those coronary arteries are going to dilate because the heart tissue needs more blood. Not only do the tissues in your body, like your skeletal muscles, need more blood, but the heart tissue itself needs more blood as well. If the sympathetic nervous system is stimulated, then if you have like a crisis situation where the adrenal medulla is putting out both norepinephrine and epinephrine, epinephrine will cause that vasodilation of those coronary vessels so that the cardiac output will increase at the same time that the heart blood flow is increasing. So now you're not only getting blood flow going out to the rest of your tissues, you're also getting blood flow to the heart tissue as well. There is something else that's called coronary spasm. So coronary spasm is when we have a temporary restriction of blood flow to those coronary arteries. Those coronary arteries are basically spasming. Okay, they're spasming, so now we have decreased blood flow to the tissues of the heart. And when that happens, the person's going to feel what we call angina. This particular type of angina would be called Prinzmetal angina, when the blood vessels are spasming. And sometimes it can be called like a broken heart. They have a broken heart. It's more of a temporary type thing because those blood vessels are just spasming. And then they're going to stop spasming. Most of the time the person should be going to the hospital because they're feeling angina, chest pain, right? But then there's some other things that are more permanent, and those are conditions that affect the cardiac output, like coronary artery disease. This is a permanent blockage of one of those coronary blood vessels or one of its branches. Here, we'll just do that. There's coronary tissue damage where even though the tissue, there might not be anything wrong with the blood vessel, but the tissue is dying. That's called a myocardial infarction. And then there's heart failure, and that occurs when the cardiac workload, the heart rate, the contractility, it increases so much above the resting level that the heart can't even pump the blood out. Heart's beating too fast, and it doesn't have enough filling time, so you don't have enough end diastolic volume, so you're not going to pump out very much. So the heart can't pump out enough blood to meet the body's needs. It's not able to fill, and it's not pumping enough because it's pumping too fast, so the contractility goes down. The last organ that I want to talk about are the lungs. So the lungs have these little air sacs called alveoli. And the alveoli are all being met by these little alveolar capillaries. And so when there's a lot of oxygen in the alveoli, the oxygen is going to leave the alveoli and go into the blood. So what we see in the lungs is that whenever we have an alveolus that has a lot of oxygen, the blood vessels are going to dilate. That's different from what we've been talking about in the rest of the body. In the rest of the body, we said that if the tissues had high oxygen content, then the blood vessels are going to constrict. Because the blood vessels are saying, we don't need more blood at this tissue. It already has enough oxygen, right? So that's what happens out at the tissues. But at the alveoli, the blood vessels are dilating because that alveolus has more oxygen, so more oxygen will be able to leave the alveolus and go into that blood vessel that has more hemoglobin to hold on to that oxygen. In the exact opposite, if an alveolus has low oxygen levels, the arterioles or the capillaries are going to constrict, because why should they dilate? There's not enough oxygen there anyway. They want to be efficient. They're only going to dilate where that alveolus has plenty of oxygen. And in the tissues, the exact opposite happens. If a tissue has low oxygen levels, then those blood vessels are going to dilate because it wants to bring more oxygen to those tissues. Let's talk about exercise. When we talk about exercise, before you even exercise, your sympathetic nervous system gets stimulated and your heart rate goes up just by thinking about it. Then during light exercise, you're going to have your blood vessels will vasodilate because your blood vessels want to bring more blood to your tissues. You'll have an increased venous return. So you want more blood going to your heart. You want more blood going to the rest of your tissues. So you get vasodilation and you get increased venous return. The more blood you have coming back to the heart, the more blood is going to go out. That's the Frank-Starling law. More in, more out. And then the more stretching that you have, that in the atrium, that's that Bainbridge reflex. That's going to stimulate your SA node so that your heart rate increases. So you're going to increase, you're going to increase heart rate and you're going to increase stroke volume. So you'll increase cardiac output. Now, when you're exercising more heavily, your cardiac output is going to increase towards maximal levels. Cardiovascular Center gets stimulated. You can actually increase your cardiac output to 20 to 25 liters per minute. You're going to shut off the blood to the non-essential organs. You don't need blood going to your digestive, your urinary, or your reproductive organs. Right? That's what sympathetic stimulation does. It shuts off the blood going to those non-essential organs. You don't need that for fight or flight or exercise. And basically, during heavy exercise, your blood is just going to race. Your heart is going to send the blood to the lungs, then back to the heart, and then the heart's going to send it out to the skeletal muscles, and then back to the heart, and then back to the lungs to pick up more oxygen, then back to the heart, then back to the skeletal muscles, and back to the heart. And it's just going to race around those three areas. Your blood flow will also increase going to your skin because then you can sweat more of that fluid out and you can decrease your body temperature. Because at this point, if your muscles are working that hard, your body temperature is going up. Trained athletes are going to have larger hearts. Okay? Because they have increased the size of their cardiac muscle, they're going to have a greater stroke volume. So when we compare this to a non-athlete and we look at the same cardiac output, the trained athlete will just normally have a lower heart rate. So if we have an athlete that has the cardiac output of around 5 and we compare it to the non-athlete who has a cardiac output of around 5 liters per minute at rest, and they have a bigger heart, so their stroke volume in the athlete is going to be greater. So we see 100 mils per beat versus 60 mils per beat. So the athlete has a greater stroke volume because their heart's bigger. To get to the same cardiac output, that athlete only has to have their heart beat around 53 beats per minute. Whereas a non-athlete would have to have their heart beating 83 beats per minute in order to have the same cardiac output. Okay? Just because that trained athlete has a bigger stroke volume because of a bigger heart. So we're going to look at one more thing, and this again, it's going to look like repetition to you, and that's good. You want this to be repetition. In the other cases, I was just talking mostly about when you're not having a huge amount of blood loss. It was just your blood pressure goes down or your blood pressure goes up, and we talked about what happens with the autoregulation, the short-term response, and then the long-term response. This last slide is talking about your cardiovascular response to like major blood loss, which you get when you have hemorrhaging and then go into shock. So shock is when your blood pressure plummets, right? This is a big deal, hemorrhaging and shock. So the immediate problem when you have hemorrhaging and shock is that you need to maintain adequate blood pressure so that you get adequate peripheral blood flow. You need your blood pressure to be high enough to get that blood to your tissues. And then the long-term problem then is that you have to bring that blood volume back to normal. You're hemorrhaging, and the person is hemorrhaging, losing a lot of fluid, losing a lot of blood. We need to get the blood volume back up. So this is what we get. It all looks very, very familiar. Significant blood loss will decrease your blood pressure and blood volume, so you're going to have those same short-term and long-term responses. The nervous system, in the nervous system, the baroreceptors and the chemoreceptors are going to be stimulated. You also have these emotions. When a person is hemorrhaging, they're going to have emotions, pain, stress, anxiety, fear. All of those things are going to stimulate the hypothalamus. So stimulating the hypothalamus, where those emotional centers are in the hypothalamus, along with stimulating the baroreceptors and the chemoreceptors, that will activate the sympathetic nervous system, and we get sympathetic nervous system activation. This is where the medulla, the adrenal medulla will release norepinephrine and epinephrine. Norepinephrine and epinephrine are going to contact the heart and the blood vessels. Norepinephrine at the heart is going to bind to which receptors? Beta 1. That's going to increase your cardiac output by increasing heart rate and contractility. Epinephrine increases that contractility. Blood vessels, when norepinephrine contacts those blood vessels, that alpha 1 receptor, what are we going to get? Vasoconstriction. And the last thing we end up getting with sympathetic activation is that blood that's been hanging out in your veins. Veins is like a blood reservoir. That's going to be mobilized. It's going to be released from the veins. It's not going to be stored there. We need to increase the amount of blood. We've been hemorrhaging, right? So all of those things then are going to increase the blood pressure and increase the blood volume. At the same time, the endocrine system kicks in. This is going to be it's going to respond at the same time, but it's going to try to help with a long-term improvement to increase your blood volume. The kidneys release erythropoietin, which increases your red blood cell production. The kidneys release renin, which stimulates the release of ADH and aldosterone, as well as angiotensin II. We'll talk more about that when we get to actually fluid balance in chapter 27. We'll talk more about that then, what angiotensin does. But ADH and aldosterone are going to increase your blood volume by making you retain more water at the kidneys. So between the increased red blood cell production and the increased water retention at the kidneys, those things will cause you to increase blood pressure and increase blood volume long term. Try to bring that blood volume back up. So that sounds very familiar to what we were talking about before, right? This is just a very immediate, more severe case when you're hemorrhaging and going into shock. All right. That's it.